Good morning, once again, Ricardo.
Yes, good morning.
All right, thank you so much for joining the series this morning. I'm going to turn it on now so that the participants can join.
Thank you.
Is your mother going to be joining us today?
So actually, yes, my colleagues from Italy will join as well, and then probably some of the perio residents from U of M.
Okay, I'm looking for an opportunity to tell. So how are they going to see the video, or from your? How are you going to watch it?
I will watch actually from my screen.
Okay, no, how would they watch it?
Oh, they registered on the webinar.
I see. Okay, I'm going to put it on Facebook as well. I just wanted to use an opportunity to wish
fantastic. Yes.
You know, if your mom is out there, I'm going to wish her a happy Mother's Day. Okay.
Fantastic.
All right. So we are live now. We're going to be expecting the participants to start attending. So we'll just give a few minutes for people to join. Most people are going to be joining from Iraq and sometimes some places in the Middle East. Say hello to a couple of them before we get started.
Fantastic. Thank you.
All right. Milad Joffrey. All right. Is that Dr. Carmine is your mom, right?
Yes, actually, it's my dad.
Okay, dad. All right. Okay, nice.
And I guess they will. My family will also stream from home in Italy.
Okay, nice. This is really cool. Thank you for your continual support of our webinar series. I want to call on Abu Al Hassan. Hello, Abu Al Hassan. How are you? Dr. Al Hassan, if you can hear me, you are able to speak. If you can unmute yourself, I just wanted to say hello.
Probably she's taking some time to connect.
Yes. Anyway, I'm just gonna pick somebody. Let me see. Dr. Nathan, good afternoon.
Yeah, good afternoon. How are you doing?
I'm fine, thank you. Where are you watching the program from?
From Abuja in Nigeria.
That's the seat of power. You are very close to the people there. Nice to hear your voice. Anyway, thank you. I just wanted to say hello to someone out there. Thanks for always joining us.
Thank you. Yeah, thank you for your efforts. Quite interesting lectures. Thank you very much.
All right, no problem. I'm gonna go. Let's see, one more person before we get our speaker here. Mohammed, how are you? Mohammed Al Tabatai, how are you? Mohammed, can you hear me?
Hi, how are you, doctor?
Nice. Where are you calling in from?
I am living in UAE right now, but I'm originally from Iraq.
Interesting. So are you close to Dubai?
Yes, I am living in Sharjah, like 15 kilometers from Dubai.
One of these days we're going to have our dental webinar series right from the UAE. So
yes,
we have to keep in contact.
Thank you very much for your efforts, doctor.
No problem. Anyway, guys, welcome to dental webinar series today. We do have Dr. Ricardo in the house today, and I'm going to give him the forum shortly. Dr. Ricardo currently is finishing up from the university, has graduated. Congratulations.
Thank you very much.
From the Department of Periodontics and Oral Medicine of the University of Michigan. He graduated from the University of Rome in 2016 and joined the Italian Society of Periodontology in the year 2017. And since 2018, he enrolled in a research clinical specialty in periodontics at the University of Michigan. His research activity focuses on peri-implant bone regeneration, mucogingival plastic surgery, amongst others. Dr. Ricardo has been a recipient of several awards, actively published in international peer-reviewed journals, and is currently serving as a reviewer of well-known journals. Dr. Ricardo, congratulations on your graduation. And I wanted to, shout out to your mom if she's there. Happy Mother's Day to your mom who is watching all the way from Italy. I'm going to see if I can get you to speak. I just want to say hello to your mother. This is Mother's Day, and somebody's mother is on here. I'm going to look for you. What's mom's name on the
chat? Probably you can pull out my family that is under the name of Carmine di Gianfilippo.
Carmine. Okay. Yes. I'm going to give them. I want to see. Your mom is able to speak. We can see if you want to let her know. Okay.
I don't know if someone from my family or my dad would like to speak.
Yes. If anybody from your family, if you can hear us, we just wanted to see you and say hello all the way from Italy.
Or I don't know if they feel confident in English. But
it's okay. You can say it in any language. It's okay. We understand. Tell them to go ahead and turn on their microphone. I want to hear from them before we start. This is it's not easy to to see. This is the first time I'm seeing somebody's family in here.
Okay.
All right. So,
I wrote them in the chat. However, I can start, and then if
okay, maybe towards the end, I want to say hello. I want to see your mom and wish her a happy Mother's Day. But anyway, welcome to the series today. We're going to get started. I will stop sharing my screen, and we can get started.
Okay. So, thank you very much, Dr. Honoribe, and I would like to thank also the Hands Health Society for organizing this great series of events. And as you said, Happy Mother's Day is really a joyful day. Today, we will investigate guided bone regeneration as a practical approach to develop the site and the bone grafting around implants. In particular, today we will focus on two aspects that are flap manipulation and materials. As you said, my name is Riccardo Di Gianfilippo, originally from Italy, and I will give a brief background on myself. I graduated in Italy, where I joined the practice of my dad and also my first mentor. And then since 2018, I joined the group of the University of Michigan, first as a researcher fellowship, and then as a resident master in periodontics. And the graduation for my master's in periodontics was just 2 days ago, May 7th. But now, without further ado, let's move to guided bone regeneration. Today, we will fly on the definition and biological principles, but then we will have a very practical approach. We will review the indications for guided bone regeneration. We will review the clinical steps. In particular, we will focus on flap management. We will review the materials, including the choice of the bone grafting and the membranes we can use. We will see what are the predictors for the outcomes. And in our next seminar, we can investigate more in depth some advanced items such as limitations of guided bone regeneration, management of complications, soft tissue augmentation after bone augmentation, and the alternatives to guided bone regeneration. So let's start. What is guided bone regeneration? GBR, or guided bone regeneration, is a surgical technique that use barrier membranes to separate the deficient site that we want to augment from the soft tissue. And this exclusion induces a protected environment that favors bone regeneration. The concept was applied to dentistry in the 80s when a researcher from Sweden, Christian Dahlin, developed some Teflon capsule that could separate the soft tissue from the underlying bone, and he was able to induce bone tuberosities or exostosis outside of the bone envelope. Today, the technique is based on the use of bone grafting particulate around the site we want to augment, covered by an occlusive membrane, and then the mucosa is moved coronally to cover membrane and bone grafting. Also, for the sake of the presentation, we focus on terminology. Guided bone regeneration is a site development for bone grafting around implants or around the dentulous ridges. So today we will not speak about bone grafting around teeth. That will be best described as guided tissue regeneration that follows other principles. So guided bone regeneration focused on augmentation of bone around edentulous ridges or implants. But what are the indications for guided bone regeneration? First is feasibility of implant positioning, meaning that sometimes the bone can be so deficient that it's impossible to place the implant. For example, in this case, it was a young patient who lost a canine, and then we can see how after the healing, the bone was 2 millimeters in width, and there was even a faciopalatal communication. Tracking back the story of the patient had an impacted canine that was extracted in oral surgery, and the healing was dramatic with a severe bone resorption. So this case was approached with guided bone regeneration with a barrier membrane and bone grafting to create a protected environment for healing. The healing was very uneventful without complication throughout the follow-up period. And at the follow-up, we were able to regenerate a significant amount of bone from 2 to 5 millimeters and from 0 to 8 millimeters. It allowed placement of implants in a favorable prosthetic position. And then I would like to thank the prosthodontist, Dr. Uvo Onoribe, who created a very nice crown. A second indication is to place implants in a prosthetically more favorable position. For example, often the position of the bone is not the ideal to place the implant. For example, in the anterior maxilla, even if we have enough bone, often the bone is too horizontal. That is unfavorable comparing the position of the implant that often needs to be placed more vertical, especially if we aim for a screw retained restoration. In this case, old patient who lost the tooth because of a recurrent endodontic abscess and untreatable endodontic prognosis. The patient had 2.3 millimeters of bone width and all the ridge was moved palatally. After flap elevation, we can see how the bone was deficient, but the bone was still enough to place the implant, despite there was a dehiscence on the facial side. The case was approached with a membrane, bone grafting, tension-free primary closure. The healing was uneventful without any exposure. And at the stage 2, when I opened the implant after 6 months, we were able to successfully regenerate very thick bone facial to the implant. For further augmentation, here I placed a soft tissue grafting. And we can see how the ridge was significantly developed from a very knife edge crest to a very thick ridge. So the second indication is to place implants in a more prosthetically favorable position. And sometimes the ridge significantly moved lingually after the extraction. We see that after the extraction, the facial bone often is completely gone, and the available bone is completely lingual. That is not favorable to place the implants. After guided bone regeneration with bone particulate and membrane, we can significantly improve the bone anatomy and we can place the implant in a more favorable position. A third indication that is very important is for biological stability. Indeed, even if we have bone to place the implant, and even if we have bone to place an implant in a favorable position for restoration, if the bone is very thin, then the bone is gonna resorb. In this study, in the year 2000, more than 3,000 implants were placed. And the amount of bone facial to the implant was measured at the time of implant placement, and then was measured again after 3 months. The researchers saw that if the bone thickness before placing the implants was less than 3 millimeters, after 3 months at the time of the stage 2, the bone was already migrated apically, meaning that there was already a phenomenon of bone loss. So, if at the time of implant placement, the bone facial to the implant was more or equal than 1.8 millimeter, after 3 months, there was no changes in the bone crest or even bone gain. But if at the time of implant placement, the bone facial to the implant was less than 1.8 millimeters, then after 4 months, there was already a phenomenon of bone resorption, and this vertical bone loss was more accentuated the thinnest was the bone at the time of implant placement. But then we can ask, is this vertical bone loss clinically relevant? The answer is yes. Indeed, bone thickness, vertical bone loss, and recession are correlated with each other, so that the risk of recession around implants is 100% if the bone thickness is less than 1.2 millimeters. And the risk of recession around implants is 80% if there is a vertical bone loss more than 1 millimeter. So we understand the crucial importance of having thick bone, not only to place the implant and to place the implants in a favorable position, but also for stability of bone and soft tissue throughout the years. So after an extraction and reevaluation, we need to ask ourselves, can we place the implant without any bone grafting? Can we place the implant, but we need to augment the bone at the same day of the implant placement? Or it will be better following a staged approach with bone grafting first, then we wait 6 months, and then we can place the implants. Let's review these 3 cases. Sometimes we have very thick bone, and we can place the implant in a very favorable restorative position. In this case, we can directly go ahead and place the implants without any bone grafting. We can place the implant in 2 stages, saying that we place the implants first, and then we connect the healing abutment later. Or we can even connect the healing abutment and the implant in a single stage approach, meaning that if we have a very thick ridge, that is very favorable for implant positioning, and we can place the implants with very thick bone, then I can directly connect the healing abutment. And after suture removal, all the work is done. We have just to wait for 3 to 4 months to send the patient to the restorative doctor or the prosthodontist to restore the implant. Other time, there is thin native bone. There is enough bone to place the implant, and there is enough bone to place the implant in a favorable position and to achieve primary stability. But we might have a dehiscence, or we might have with very thin bone facial to the implant. And then we learn the importance of having thick bone. So in this case, this patient was referred because of missing bilateral second premolars. And after flap elevation, there was just enough bone to place the implant, and the bone was just enough to cover the implant. So in this case, knowing the importance of having thick bone, the case was approached with a membrane, bone grafting, no complication throughout the follow-up. We can see how the ridge significantly increased in thickness after the procedure. And at the stage 2, there was thick bone facial to the implant. And then we were able to place the crown. And then in this case, there was favorable contour for bone and soft tissue. Other time, the bone is so resorbed that it is impossible to place the implant. And we should rather follow a staged approach with bone grafting to develop the site first, and then to place the implants in a staged approach after 6-7 months. So if bone anatomy does not allow a restorable position or does not allow place the implant with primary stability, then we should rather stage and then do a guided bone regeneration first. Like these cases, we don't place the implant, we place bone grafting and membrane only. We can see how the ridge is significantly augmented throughout the follow-up. We can place the implants now in a very favorable site with a lot of bone all around. And after the healing, we can still expect a lot of bone around the implants. So we really need to think case by case. Can I place the implant in a favorable position with a lot of bone? Can I place the implant but I should rather augment the amount of available bone, or I should rather follow a staged approach? But regardless if I follow a simultaneous or a stage approach, the steps for the site development are the same. And we will review in depth these steps one by one. starting from incision design, flap manipulation, cortical penetration, placement of an occlusive membrane, bone grafting, suturing, and post-operative care. This patient was referred to me again because the socket didn't heal after the extraction. Again, in this case was recurrent endodontic abscess. We see that after flap elevation, the bone was completely unhealed after the extraction. Cortical penetration, membrane and bone grafting, tension-free primary closure, an eventful healing throughout the follow-up. And at the time of the stage 2, the bone was even growing on the top of the implant. I had to remove some bone to expose the implant platform. I also did soft tissue augmentation to augment the ridge profile that was concave and to create a very convex profile, very favorable for crown restoration. So let's review the steps one by one. First, the incision design. We do an intrasulcular incision on the adjacent teeth. And we might need to do a vertical releasing incision to expose more bone and to gain more access. This vertical releasing incision can be done only one on the two sides of the flap, or two vertical releasing incision, and can be done one teeth away or two teeth away from the area. It is highly recommended to move the vertical releasing incision at least 1 tooth away from the area we want to bone graft, as the area of the bone grafting is very sensitive and needs to be kept closed and away from the outside oral environment as much as we can. But now let's see, how do we need to incise the edentulous ridge? If you have an edentulous ridge, we can incise in the middle. It's not recommended to incise on the palatal side, as these teeth create a stress on the flap, and the stress is higher the more the flap creates tension around the teeth. So we should rather move the incision slightly facial rather than palatal, so that we can reduce the stress that these teeth create on the flap. Both mid-crestal incision in the middle of the ridge or the incision more facial work very well. The mid-crestal incision is favorable for biological purpose. Indeed, some studies injecting ink in some cadaver flow, they see that the vascularization of the ridge stops in the midline. So in this case, mid-crest incision is very favorable with an eventful healing. And again, mid-crestal incision is favorable. And there is no opening of the site. But as I said, we can also move the incision slightly crestal, slightly facial, to reduce the stress. And still, after the follow-up, everything looks good. So in this case, we can move the incision significantly facial. And still, everything stays close. So both mid-crestal and facial approach work very well. But now we need to speak about one of the key factors for guided bone regeneration. It is the coronal advancement. So how much we can pull the flap coronally to cover the bone grafting, as primary closure and no exposure is a crucial is crucial and very important. There are two ways to improve the flap elasticity and to move the flap coronally to cover bone grafting and membrane. One is called linear releasing. That is one horizontal incision from one side to the other of the flap to incise the periosteum. Indeed, it's the periosteum that keeps the tension, and we need to incise the periosteum from one side to the other to release the tension. Another approach is called mucosal detachment, as we completely detach the flap from the periosteum. In this case, the flap has really a lot of freedom to move coronally and to close the flap. Let's see these two techniques. The linear releasing can be done with a blade. or with a scissor. And we don't have to go deep into the flap, just enough to incise the periosteum. And we can incise one time or multiple times, depending from how much we want to open and how much we want to pull coronally. Tension-free primary closure. In this case, this surgery is taken from a publication that showed a significant bone augmentation. The mucosal detachment, I said, the process is different. We want to detach the flap from the periosteum and then the periosteum from the flap. And we can see how we have two layers, the flap, independent by the periosteum, which is independent from the bone. And then we place bone inside this little pocket. Tension-free primary closure, and again, very thick bone augmentation. I had the pleasure to be involved in some preclinical research to investigate which one of these two techniques is best to improve coronal advancement and to pull the flap on the top of the bone grafting membrane. So comparing to no incision at all, linear releasing incision and mucosal detachment, we see how the linear releasing incision was able to increase coronal advancement of approximately 4 millimeters, while the mucosal detachment is able to increase coronal advancement of approximately 8 to 9 millimeters. And we also saw that the more the periosteum was detached from the mucosa and the more we could expose the mucosa, the more we had advancement of the flap. Next step of after flap manipulation, we need to ask, do we need to do cortical penetrations into the bone? The advantages of cortical penetration is to create some bleeding from the site. And we know that the blood brings some very important growth factors and signaling molecules that improve our regeneration. So far, there is only one study asking the question, do we need to do cortical penetration to improve the bone gain after GBR? And it seems that with the cortication or without the cortication, the amount of new bone formation is the same. So it's still under question if it brings any advantage. However, preclinical studies on animals comparing no decortication with one decortication, with multiple decortication, or removing a very thin layer of bone, then showed that each of the groups with decortication brings more bone compared to no decortication at all. So far, there is clinical recommendation to do decortication, despite the scientific evidence is still under development. After flap advancement, after decortication of the site, we need to ask, what membrane and what bone grafting do we use? There are many membranes and many bone grafting. So let's dive into the characteristics and the choice. Membranes can be classified in absorbable and non-resorbable membrane. Obviously, absorbable, absorb on their own, so we don't need to take them out, while non-resorbable membrane stay there. We need to do a surgery to take them out. What's the advantage of non-resorbable membrane? They can be reinforced with titanium, so they are very rigid. They can create space, they can maintain the space over the follow-up, and they can maintain stability of the underlying bone grafting. On the other hand, what's the advantage of absorbable membrane, and the most used are collagen membrane? They don't need any re-entry surgery to take the membrane out. They are tissue friendly. There is a lower risk of complication. And if there is complication, overall, the severity of the complication is lower. The collagen absorbable membrane can be classified in cross-linked or non-cross-linked, depending from how tight the fibers of collagen are together. And the cross-linking process influences tissue integration, meaning how friendly is the material with the soft tissue, and also how long the membrane lasts. At this point, we need to ask, how long should the membrane function act as barrier? I take this screenshot from a Gastlik brand from the website of the Gastlik, that is a company that produces membrane bone and also a biological agent. Expert oral surgeons have estimated that a membrane using in GBR should maintain its barrier function until provisional matrix and woven bone are present. As consequence, barrier duration is considered to be necessary for 4 to 6 weeks. And if we see animal study, the woven bone is completely formed and start to become lamellar bone in 2 months. And if we see bone studies and human studies, woven bone is completely formed and start to become lamellar bone in 4 months. So the choice of the membrane is very important because if we want to grow a lot of bone, we should rather choose a membrane that lasts 4 to 6 weeks or even longer, even 4 months, to create a stable environment for bone augmentation. How long the membrane lasts have been investigated in this study. A non-cross-linked collagen membrane has a degradation that is significant in between 2 and 4 weeks. So the barrier function seems to drop significantly after 2 weeks. If we see a cross-linked membrane, the drop in barrier function is later, in 4 to 8 weeks. But even in between different cross-linking methods, some cross-linked membranes drop in the barrier function between 4 to 8 weeks. Other cross-linking methodology, for example, the ribose cross-linking, create a membrane that are long-lasting throughout 6 months. In this slide, I want to say that non-cross-linked membranes last less. Cross-linked membranes last longer. And even in between cross-linked membranes, there are different resorption process depending on the enzyme. So that Biomed Extend, aggluteraaldehyded cross-linked membranes, has a resorption between 4 to 8 weeks, as compared to O6 membrane, a ribose cross-linked membrane, that seems to maintain barrier function throughout 6 months. But then at this point, why we don't just use a long-lasting membranes for every case? So that if the membrane lasts longer, it improves the occlusion properties, I gain more bone. Occlusion is a double-edged phenomenon. Indeed, the more I have occlusion properties, the less the membrane is tissue-friendly, the less the membrane integrates with the flap, the less is the vascularization, and the more there is a risk for foreign body reaction. So the short is the time when the membrane resorb, the more the membrane is tissue-friendly. I can expect less complication. But the longer the membrane lasts, the more it occludes the space and create a protected environment that is good for bone gain. But the less is tissue-friendly, and there is a risk of complication. Indeed, the risk of complication, the risk of exposures, is less for native collagen, is more for cross-linked collagen, and is even more for non-resorbable membrane that never resorb and they need to take them out. So the choice of the membrane, regardless of the brand, is on the lasting in terms of barrier function. If we really need to graft a small defect, a little dehiscence, or there is no dehiscence, we graft only to augment the size, to increase the phenotype of an implant, then we can choose native collagen membrane that lasts less, but we don't have risk of complication or lower risk of complication. On the other hand, if we have to do huge augmentation, in a staged approach, because it's impossible to place the implant, then I would rather choose a cross-linked collagen membrane or a non-resorbable membrane that keeps the space more. Membrane should be fixated. To create the bone and the membrane independent from the flap, to increase wound stability, that is important, and because studies show that fixation increases the bone gain. 3 ways to fixate the membrane: screws, pins, or absorbable suture. There is really no preferred way, and each clinician at the end develops their own preferred way to fixate the membrane. Indeed, each of these fixation methods brings some challenge. For example, if you try to screw the membrane inside, the membrane might twist. If you try to fixate the pin, the patient might complain that feels the pressure during the fixation. And if you use absorbable suture, we end up having some localized inflammation closer to the membrane we really don't want. So each clinician at the end choose the type of fixation methods that is more comfortable. And however, fixating the membrane, regardless of the fixation methods, is very important to create stability of the site and to increase bone augmentation. Now we need to choose which bone grafting do we need to use. Autograft come from the same individual, the same patient, and was considered the best bone grafting materials for biological properties, as it has osteogenetic properties, meaning that bone cells are in the bone grafting itself. Osteoinductive, meaning that it can induce bone augmentation through bone signaling molecules and growth factors. And osteoconductive, meaning that the particulate bone grafting occupy the space, create a space, and is a scaffold for bone augmentation. Allograft comes from a different individual, meaning mainly donor of bone or cadaver bone. And is osteoconductive, meaning that is a particulate that can maintain the space. It is not osteogenic, meaning that it does not contain cells that induce regeneration. Indeed, if we use any external materials with cells, our body will develop an immune reaction. So only autograft from the same individual have osteogenetic properties, while allograft, xenograft, and alloplast only hold the space. Allograft can expose growth factors and bone signaling molecules only if demineralize, FDBA. Xenograft come from not a human species, from animal or from plants. The most used animal is actually cow, bovine bone. And alloplast is a synthetic bone, but is still under development. Mainly used for tissue regeneration around teeth, for example, GEM21, beta-TCP. But the research in alloplast for guided bone regeneration seems not to be, actually at least to be less evolved as compared to the clinical application of allograft, xenograft, or autograft. Autograft, as I said, was the biological gold standard in terms of bone augmentation. How we can collect bone with a scraper, with a trephine that can directly give particulate bone, or with trephine or piezo surgery, we take out a block of bone from a different area from the same individual, and then we can mill the bone in little particles and we can use it. So where are the areas where we can safely collect autograft? If we are working in the posterior mandible, we can extend incisor more distally and take from the ramus. If we can work in the posterior maxilla, we can extend incisor more distally and we can take the tuber. If we are working in the anterior mandible, we can expose more apically the chin and we can take from the chin. However, we can understand that to collect autograft, we need to extend incision a little bit more. And if we are working in areas where there is no good site to take a lot of autograft, then we need to open another site. So autograft is very good biologically, but increase the morbidity for the patient. So now we need to think that allograft and xenograft have unlimited quantity, because if we need more, we can just buy more. We don't have to scrape more and take more bone for the patient. There is no need to open larger flaps or open a second surgical site. In addition, autograft lasts shorter period amount of time as it resorbs faster, while allograft and xenograft resorb slower. It is good for space maintenance over time, in particular cortical allograft and xenograft. So now we need to ask, what bone grafting do we use? The best option is a combination. So if we want to augment the bone around an implant, we can use autograft, that is the best biological properties, in contact with the bone, with the implant dehiscence. And there are xenograft or allograft that can hold the space on the outside and can maintain volume stability. So if I'm doing bone augmentation to cover a peri-implant defect, I want to use a layer approach with autograft for best biological properties around close to the implant, and bone from animal or from cadaver on the outside to maintain the space. If I'm doing a staged bone augmentation, I follow the same approach, autograft and either xenograft or allograft, but mixed together. In this case, I can combine the biological properties and a boosted bone augmentation of autograft with xenograft and allograft in terms of bone, in terms of dimension stability. After flap elevation, we need to close. We need to close with 2 layers of suture. So on the crest, we close with monofilament synthetic sutures that do not trap plaque. Non-resorbable suture, meaning that we have to decide when to take them out. And we use a double layer technique with internal mattress that hold the tissue together, and single interrupted on top, then close the edges of the flap together. On the other hand, on the vertical releasing incision, that are at 1 or 2 teeth away from the bone grafting, this area is less crucial, and we can use self-absorbable sutures, such as chromic gut, PGA, or any self-absorbable suture to keep the flap closed. And in this case, we don't have to remove the suture, and the suture will come out on their own. Indeed, taking the suture out in the alveolar mucosa often can give some discomfort from the patient. So after flap management, after materials, bone grafting, and membrane, after tension-free primary closure, the surgery is not completed. It's important to prescribe medication to make sure that the post-operative period is uneventful and the patient doesn't get scared if it comes with a bruising or a swelling. For analgesic effect to control pain, the best option is to do ibuprofen alone or with acetaminophen. So any anti-inflammatory drugs alone or with acetaminophen. Alternative is to use opioid, but due to the increasing risk of opioid dependence, then our practice really should move away from opioid and should come closer to non-steroid anti-inflammatory drugs and acetaminophen. The patient can take 1 tab of NSAIDs every 6 hours alone or together with 1 tab of acetaminophen 500 milligram every 6 hours. The patient can take both medications together every 6 hours, or can take ibuprofen first, after 3 hours acetaminophen, after 3 hours ibuprofen, after 3 hours acetaminophen, and so on. So that each medication is taken every 6 hours, but the patient takes one medication every 3 hours. Because of we did releasing incision, the patient can expect some swelling due to tissue edema and releasing of fluid inside the tissue. So we prescribe steroids in a tapering dose, 200 milligram tabs, 4 tabs the first day, 2 tabs second day, 2 tabs third day, 1 tab fourth day. So tapering from 8 milligrams to 2 milligrams, so that I can cover the patient with steroids at the peak of inflammation, and I don't need steroid after the healing process already is in a good point. And then every time we use bone grafting or any type of grafting, then we should cover the patient with antibiotic. And the worldwide use antibiotic is often amoxicillin coverage for a week. Post-operative care is not only medication, but it's extremely important for clinicians, surgeons, and prosthodontists not to create trauma on the healing site. It's extremely important to adjust any prosthetic device that can be, for example, a flipper, or the patient may wear S6 retainer or a Maryland bridge. They should bring no contact for the first 4 weeks. And if we want to reline the flippers, if we should actually wait 3 months. Now, if the surgery, everything went well, how much do we expect for gaining? The average bone gain is actually 3 to 4 millimeters. So if you see speakers who gain 10 millimeters of bone, it happened in that case, or they are expert clinician. But this is not something we can replicate on a daily basis. The overall gain indeed is between 3 to 4 millimeters. And factors that can improve the gain is, as I said, use of additional xenograft or autograft in addition to autograft to maintain the space, or use the additional use of membrane on the top of the bone grafting, especially long-lasting membrane can improve the gain, or membrane fixation can improve the gain. On the other hand, factors that can increase the risk of exposure are systemic disease, including diabetes, smoking. In this case, a retrospective study from our group showed that diabetes and smoking increase of 10 times risk of complication. We saw how the choice of membrane can drive the risk of complication. And in case there is of complication, there is less bone augmentation. Complication is a huge topic that deserves its own seminar, so it will be treated in a separate way. So today we covered many points. We saw how GBR allows feasibility of implant positioning, improved implant positioning, and long-term biological stability. We see the critical importance of step-by-step procedure, including flap manipulation, wound stabilization, and tension-free primary closure. We see the advantageous use of xenograft and autograft, xenograft and allograft in compared to autograft. We see the role of a barrier membrane to keep the area stable in barrier function to maintain the area stable. At the same time, the crucial role of tissue integration to reduce the risk of complication. And we see that the prediction of outcomes is 3 to 4 millimeters. So keeping the 3 millimeters in mind, now we know if we need to do a staged augmentation, or we can place implants and to do augmentation at the same time. If we need to augment more than 3 millimeters, probably is a wise choice to delay the implant placement to develop the site first, and at the re-entry to do a new implant with GBR. And at this point, I would like to thank every one of you for this, for your patience and following this webinar. And I want to thank my family first, everyone who supported me throughout my development, my research mentors, the University of Michigan, and Dr. Uvo Onoribe for organizing this great series of events. And Dr. Onoribe, I believe you are muted.
All right, thank you so much. That's been this is very, very detailed. Thank you so much for your diligence in putting these lectures. You know, I see you at the top. I see you at the top for sure. You've been very, very. We do have some questions here. So if you are able to see the question and answer.
1 second that I open. Okay, yes, I see the questions. First, actually, I would like to thank you, Dr. Onoribe, for actively participating in the prosthodontic rehabilitation of some of my DGBR. So your skill as a prosthodontist bring up the team. So it's not the surgeon first or prosto first, it's the team that comes together.
Yes, yes.
Well, anyway,
I was going to ask you before you jump into these questions. You know,
yes.
So when you finish you place healing abutments, I know you keep the healing abutment for about 3 months. Is there any room for a custom healing abutment so that the emergence profile will have all that time, so we don't have to go back in there and sculpt?
So very good question. So if I place implant without any GBR, I can place the healing abutment. It can be a customized healing abutment to shape the emergence profile of the mucosa so that it's already shaped and prepared to receive the crown. However, if I do GBR at the time of implant placement, then I prefer to cover the implant on top. Okay. So I place the healing abutment only if I don't do any simultaneous bone augmentation. And in this case, yes, a customized healing abutment that can prepare the soft tissue for the crown is highly recommended. But if I do any type of bone augmentation simultaneously to the implant placement, then I prefer to submerge everything with no healing abutment.
Okay, nice. Okay, please go ahead. The questions are out there. Yeah.
Can't we use a non-absorbable suture with non-resorbable membrane to reduce inflammation? Yes, so exactly. So, in my practice, I almost always use actually I always use a resorbable membrane. And then non-resorbable membrane are used for very large defects. So for sure, we can use non-absorbable suture on top a non-resorbable membrane. Probably, Dr. Mohammed, you mean for internal suture? Internal suture. So if you want to fixate non-resorbable membrane, I strongly recommend using pin and screws, non-suture. The reason why I strongly recommend the pin and screws for the non-resorbable membrane is because non-resorbable membrane has a memory form, and even though you model, after the follow-up, during the follow-up, the non-resorbable membrane tends to open, and this opening movement creates some tension and exposure on the side of the flap. So for membrane fixation, in my practice, I use resorbable internal suture for collagen membrane and either screws or pins for non-resorbable membrane. Or sometimes I use both screws or pins and sutures to close to fixate a non-resorbable membrane. So for non-resorbable membrane, my concern is actually sutures may be a little bit weak, and the membrane can open because of memory form and create a complication exposure on the side. So I actually, for non-resorbable membrane, I strongly recommend screws or pins. I don't know if I was, as I explained throughout.
I think it's good. Go ahead. There are a couple questions.
Next is, can this procedure was used in chronic periodontitis to correct mobile teeth? So, very good question. I mentioned in the early in the definition in the presentation that GBR is used on edentulous ridges or around implants. It's not used around teeth. The procedure, the same procedure around teeth is takes the name of periodontal regeneration, or GTR, guided tissue regeneration, and is actually predictable if the tooth has an infrabony defect. So, for Dr. Ukechi, if the teeth you would like to regenerate has a bone crest and an infrabony defect that moves apically, then you can use bone grafting and membrane to regenerate the bone. But if the tooth with the chronic periodontitis has some horizontal bone pattern and there is no infrabony defect, then unfortunately around the teeth there is no possibility for vertical bone augmentation. So this technique can be used around teeth with chronic periodontitis. It's called guided tissue regeneration with the T, so GTR, and it works only if the crest is coronal and there is an infrabony defect that moves apical. But it's also another huge topic that follow different principles, so really deserves another presentation. And then I move to the third question. I have been placing implants after 3 months and they have recorded success. Have I been lucky because you said 6 months? So I took some bone histologies from GBR procedure, and I see that after I took histologies after 4 months. After 4 months, the bone is healed, and then I placed implants after 4 months. Everything looks good. At the histology, I see a huge amount of bone particles. So in terms of ridge volume, 3 to 4 months after a GBR, the bone is solid, and you can place the implant, and the implant integrate. So after other 3 months, you can connect, you can load, and everything works good. However, from a biological process, there are so many residual particles inside the bone. So we are placing the implant in a bone that is still very mature. So for a mechanical process, it's fine to place the implant after 3 to 4 months. From a biological process, probably it's better to delay the implant placement of 2 to 6 months if I'm doing a staged GBR, to let the body heal more and to remove some residual particles from the area. However, if you place implant only without any GBR, then 3 months is surely more than enough. Okay, other question. Is there indication for particular membrane? So for small defects, for mild horizontal augmentation, I usually use a short-lasting collagen membrane like BioGuide or any non-cross-linked collagen membrane. For staged horizontal augmentation, I use Biomed Extend or O6 or any cross-linked collagen membrane to improve the stability of the environment. For vertical augmentation, I use a non-resorbable membrane. However, I need to also know that the predictability of a vertical augmentation is still under question, and the risk of complication is relatively higher. So the indication for the membrane is actually collagen membrane most of the time for horizontal augmentation, and non-resorbable membrane for vertical augmentation. Another question is, are there any kind of tissue rejections when using allograft and other kind of materials other than autograft? There are very rare isolated cases described in the literature with long-term tissue rejection of xenograft. There are very rare cases described in the literature with a risk of HIV infection with allograft 1/8 million. However, the normal standard of care is actually combining autograft and non-autogenic graft, so either allograft and xenograft. So even though there are some risk of tissue rejection for xenograft, and the tissue rejection of xenograft means that the particles are pushed away, or the rejections of allograft, there is a very remote risk of infection. However, these are very remote events, and the standard of care today uses a combined approach, autograft and either allograft or xenograft.
Right. I know we do have a lot more questions out there, but I'm going to send you the questions. Is that okay?
Absolutely, yes.
So what I would do, I think you'll be able to, I don't know if you have some time, so just to give a detailed responses to all the questions. So that I'm going to, so we do have an implant course going on where all the lectures are on there. So I will put all your responses together. It's going to be part of the recording. So, and each person has to do a summary of your lecture, so everybody's listening. So it makes it more intense in terms of the listening and taking notes. So I will send you those questions at the end of today. And thank you so much. I want to appreciate you. And so your mom, happy Mother's Day. If your mom is there, if she wants to wave and say hello, she can do that. We have Dr. Palugi yes, Dr. Balis is on there, is waiting, ready to go. Dr. Balis, are you from Italy as well? Your mic is muted. Your mic is muted, sir.
Oh, sorry. Okay. Yes, I'm from Italy. Hello, everybody. And I'm actually 3 hours away from my friend Riccardo's place.
All right. Thank you so much. This is I want to call this is an Italy Day. Thank you, Riccardo, for that powerful lecture. And we're going to get started soon. Greetings to everyone watching from Italy. Dr. Balis, can you go ahead and before you do that, let me just do this so that we can get started. Thank you, Riccardo. It's been awesome having you. And that is part one of your lecture, Dr. Riccardo, right?
That's correct. This is part one. Actually, I would like to bring my apologies to Dr. Balice. I ran a little bit late.
No.
I can't wait to attend your presentation, and I learn a lot from you.
Thank you. Great presentation.
All right. So, I've been corrected. Dr. Balice, right?
Yes. Now, Dr. Uvo, you are inviting all these Italian speakers. So now you got to be more practical with the Italian accent as well.
Yes.
And pronunciations.
Yes, Dr. Balice.
We'll teach you Italian a little bit.
Of course. After I get some pasta. And so.
Wait, we're going to talk about pasta. Let me tell you in my lecture.
All right. That's awesome.
You'll see.
All right, so we're going to continue here. We do have Dr. Balice in the house today. He's a clinical assistant professor in periodontics and implant surgery at the University of Missouri, Kansas City School of Dentistry. He obtained his DDS cum laude from University of Altomoro in Italy, his home country. Dr. Balice completed his 3-year specialty training at the University of Connecticut School of Dentistry, where he received a certificate in periodontics and a Master of Dental Science degree. He's an active member of several dental organizations and has lectured internationally. Dr. Balice, it's a pleasure to have you back again on Dental Webinar Series.
Thank you, Dr. Ugo. For me, oh, okay, sorry, someone is. For me, it's a pleasure being here and be part of your of the lecture series. I really appreciate what you do, and being here for your organization is really a pleasure. So, and happy Mother's Day to everybody. So I can probably start in sharing my screen. Okay. Okay, hold on a second, because I have to put this on the side. All right. So today we are going to talk about the osseointegration. My understanding in this lecture is a part of an implant lecture, like a lecture about implant dentistry in general. So the osseointegration is a compelling part when we want to start to understand a little bit more about implants. This lecture maybe is going to be a little bit didactic, but ultimately we are going to understand what are the practical application of all the concepts that we are going to discuss today. So osseointegration, when we place an implant, what happens, why the implant and the bone fuse to each other, how an implant can be functional, and what are all these concepts that we need to take into account when we approach implant dentistry. So as I said before, I'm originally from Italy. My accent doesn't lie. Sorry, guys, you're going to have a lot of Italian accents today. And I'm originally from a town called Bari. Many people don't know where my town is. So usually I say it's the Hill of the Boot. And my university is University of Bari. It's not one of the main tourist destinations, but it's going to be at some point. I believe I'm all the time that I lecture, I put pictures of my hometown and my region, which is called Puglia. I studied also in Spain for a scholarship in the northwest tip of Spain in Compostela, and worked as a general dentist for a few years. And then I joined University of Connecticut, where I got my certificate in periodontics and a Master of Dental Science. Today, I am in the heartland, in the middle of the United States, in University of Missouri, Kansas City, which is located in Kansas City in Missouri. It's at the border of Missouri, with Missouri and Kansas, but technically it's in Missouri. So it's a little tricky. And this is the view of one of my favorite views of the town. So this is the outline that we are going to follow today. We are going to talk about implant surfaces. So how the different type of implant surfaces can affect the osseointegration. We are going to talk about a little briefly about the bone biology and also the dynamic of the osseointegration at the histological level, what happens, and so what are then the practical application of these histologic and biologic concepps. Then loading, so what is the right time to place a crown on top of our implant? And so why we have to wait a certain amount of time, and when instead we don't need to wait for the osseointegration, and also ultimately the insertion torque. Why that is important, we know that when we place implants, we have a Newton centimeter value. We are going to expand on that. So how important is that value when we place an implant? So this gentleman is not my uncle, is not my grandpa. I'm not here to talk about my personal life. This gentleman is the godfather of implant dentistry. He passed away a few years ago. He's Per Ingvar Branemark from Sweden. And he radically changed the world of dentistry in the early 80s, when during the famous Toronto conference in 1982, he presented a lecture about all his studies and introduced implant dentistry to the world of dentistry. And he described the osseointegration as a direct structural and functional connection between ordered living bone and the surface of a load-carrying implant. This definition is still valid today. Many concepts applied back in the 80s are still valid today, but of course, implant dentistry has changed a little bit. So we also, it's not exactly the same. Observations and the biomechanics of the implant and the concept that we know about implants have been changing over the years, but overall, the definition of osseointegration is the same, and we need to say thank you to Per Ingvar Branemark and after Per Ingvar Branemark, all the other Swedish authors that early 80s and 90s studies and introduced implant dentistry. For instance, these other two main authors, Albrechtsson and Zarb, in 1986, they classified 6 key factors for successful implant osseointegration. And those are very important still today. So first of all, we need a biocompatible implant material. So it has to be biocompatible, the implant that we place in the alveolar bone. The implant surface at the macroscopic and microscopic level has an important impact on the quality of the osseointegration. Also, we want to place our implant in a healthy bone, so not infected bone, and also a decent amount of bone is a decent decent quality and quantity at the same time. The surgical technique is important, as well as knowing important to know the concept of the osseointegration. So what happened at histologic level, because we want to leave the osseointegration undisturbed when we decide to go for what is called delayed loading. We are going to talk, we're going to expand on that as well. Also, the crown, the prosthetic design of our crown and the loading phases, I just said, play an important role in the successful osseointegration. So let's start talking about the material that the implants are made of. Implants are made of titanium, mostly by titanium. And today, titanium is the most widely used material in the manufacture of dental implants. It's present in the market in form of titanium, pure titanium, or also in form of alloys. Alloys meaning so a blend of different metals. So why among all the metals we decide to use, decide to manufacture implant with titanium? So first of all, it has a low weight. So it's pretty light, but also has a high strength to weight ratio. So despite it's pretty light, it's a very strong material, it's a very strong metal. Has a low modulus of elasticity. What does this mean? So the modulus of elasticity is the quantity that measures an object or a substance resistant to being deformed elastically. So to give you a practical example, rubber has a very low modulus of elasticity, so we can deform rubber under pressure. Titanium, of course, doesn't have a low modulus of elasticity like rubber, but has a low modulus of elasticity compared to other metals. And that is important because somehow we want the forces, mechanical forces, exerted to the peripheral bone. So this explains why if we extract a tooth and we do not replace the tooth with an implant, we can see progressively a bone shrinkage, or bone resorption. Instead, if the implant is in place, we can also preserve the quality and quantity of the peripheral bone. So that means low modulus elasticity compared to other metal. It's very resistant to corrosion, has an excellent biocompatibility, so it's biocompatible. It's easy to shape and to finish, so companies can manufacture this material pretty easily. And another important factor is represented by the titanium oxide layer. The titanium oxide layer is a layer of that so basically titanium, when it's in contact with air or oxygenated solution, which means fluids like bone, for instance, it gets passivated, it gets oxidized. So has the capacity of promote the adhesion, attraction of osteogenic cells. So this is an important factor because in the moment of the implant placement, this material has the capacity of attract liquids and fluids and promote the formation of bone over the surface. However, we'll see if the surface is rough, because we have machined, so smooth surface and rough surface. Very frequently we have titanium alloys, so it's a blend of different metals. The most frequent combination is 90% titanium, 6% aluminum. Aluminum decreases the specific weight and improves the elastic modulus, and 4% vanadium, so decreases the thermal conductivity. We do not want thermal conductivity, and increases the hardness. So we call titanium 6, aluminum 4, vanadium. This is the most frequent used alloy. So you probably also heard about zirconia. What is zirconia? You probably remember from your previous studies that zircon is actually a metal. In the periodic table, zircon is with the metal present in the periodic table. But zirconia is not a metal; is a ceramic. Is a ceramic that is originated by zircon, because is produced through the reduction and fusion of zircon sand, zircon silicate. Is mixed with coke and heated to its fusion point, etc. Ultimately, it get dissociated in zircon oxide and fumed silica. So zirconia is zircon oxide and is a ceramic. Why it's becoming more popular? Because there's a wave of led by patients' requests to have a metal-free type of implants. And zirconia, as I said, is a ceramic. So the company are very happy to introduce to the market zirconia because they can increase their revenue. So it's really led by a market request, but it's a very good material in terms of similar to titanium overall. It's a little bit more challenging to restore. So the restoration of zirconia implant has some limitations. We are not going to talk about that today. But I tend to prefer still titanium, but zirconia is out there, has the same color of the dentition. That's why it's pretty popular. And also there's a request by certain patients to have a metal-free type of implant. So let's talk about now the implant surfaces, and more specifically the microstructure of the implant surfaces. So you can see over here in these pictures, in this cartoon, in these figures, how there are 3 different main classes of implant surface. There is the smooth surface, moderately rough surface, and a highly rough surface. So it's pretty intuitive. Those cells that you see over there are the osteoblasts. And so it's pretty intuitive to understand how the surface with a moderately rough pattern can host in a better fashion the osteoblast inside the crypt, inside their lacunae. So that is explained in a very simplistic way why this is the best type of implant surface. Another study, this is still the same studies, the previous authors are from Wennerberg and Albrechtsson are still from Sweden. So a lot of research of early implant dentistry comes from Sweden. And they notice how the surface topography influenced the bone response and the micrometer level. Today we have smooth surface implants, minimally rough surface, moderately rough surface, which is the surface that the vast majority of implants today are made of, and rough surface. It goes by SA, which is the roughness average, and for the moderately rough surface goes from 1 to 2 micrometers. We have extensive research, extensive studies that shows how the moderately rough surface is the one that induces a better type of bone response, a better type, faster and more effective type of osseointegration. And we're going to see why. So this is these are two pictures from a scanning electronic microscope, SEM, and they show all the micro irregularities they can host and promote the blood colonization, which you can see in the rough surface. Instead, the smooth surface is pretty smooth, and it's pretty intuitive that the rough surface can work better when in contact with blood. Also, the rough surface extends the surface. If it's rough, it makes a vaster, like a wider type of surface, so increase the surface significantly. This magnification is about 250 times higher than a regular microscope. So we can see in the little details here. Now, not only the surface can be rough or smooth, but also there can be several modifications applied to a surface. So the modification can be physical or chemical, or a combination of the two, physical and chemical. But also the surface of the implant can be coated by biocompatible materials, usually calcium phosphate, for instance, or hydroxyapatite. And it can be even a combination of all the three, so physical, chemical, coating. There are many type of implant brands out there, and therefore there are different type of combinations, different type of surface modification. Every company claims that their modification induces a better type of osseointegration. This is the list of the main type of modifications of the surface. So we do have machine surface, so basically just smooth surface. Plasma spray, which are prepared by spraying a molten metal on the titanium base and results in a surface with irregularity, size and shape valleys, so how you can see in the electronic microscope. And we increase the area by 6 to 10 times usually compared to a machine surface. Also titanium spray. The titanium spray can increase the roughness way more than plasma sprayed surfaces. And they use basically micro titanium particles to induce this blasted to induce this type of irregularities. The disadvantage is that there are some possible release of titanium particles during the implant placement, and there's a new wave of implant research claiming that potentially this can be one of the reasons of perimplantitis. But we are basically opening here like a can of worms, so let's not talk about that right now. Sandblasted are the type of it's a similar process to the plasma spray and titanium spray, but in this case, it can be more parameter can be regulated, so we can decide that how many. It can be a little bit more standardized. We can decide, for instance, how many rounds, how big should be the particles that we want to use for the modification, the speed of the rotations, facilitate a little bit more standardized type of modification. Then acid etch. Usually we do the acid etch with acids in order to induce a type of chemical modification. RBM, hydroxyapatite, TCP coating are all type of TCP, the tricalcium phosphate, are all type of coating that induce allegedly they promote a osseointegration, because they are basically they coat the implant with molecules that are a component of the bone itself. And then lasers. Lasers are effective because they do not release, there's a modification without any sort of contact, basically. The advantage is that they have the property of melting the surface layer locally. Is a process that is contactless, and thermal mechanical deformation of the substrate is generally low. So they also have this type of advantages. Ultimately, we have the anodization, that is an electrolytic passivation process used to increase the thickness of the natural oxide layer on the surface of metal parts. And we mentioned how important is the titanium oxide layer in order to promote the adhesion of progenitor cells, blood, and therefore bone. So as I said before, there are several, I can say thousands or hundreds or probably thousands of implant company out there. Is a rapidly evolving industry. The global market for implant dentistry for this company, the size of it was $4.23 billion in 2019, projected to reach 5.81 billion in 2027. So it's growing. Everybody want to find the niche in this market, and all these companies promote a different type of implant surface conditioning, claiming that their surface is better than the other surface. How do we select, how do we decide which type of implant we want to use for our patients? Well, my recommendation is to go for implant companies that have a very good customer service, possibly worldwide, because the patient, whenever the patient goes for possible implant complication, it's going to be easier for the dentist to find parts and pieces. But also you want one of those companies that have some research and there are proven evidence of their success. And there are many different type of implants out there. These are just a table of a few examples of implant surfaces, and what this company prefer to use to condition their surfaces. I don't know, we say now Nobel Biocare uses the anodized type of modification, or the laser ablation by BioHorizon, or the plasma sprayed by Straumann, sandblasted and etched by Straumann as well. There are different possibilities out there. So you want to know actually what type of, if you decide to go for an implant and pick one implant in particular, you want to understand what is the type of surface, surface conditioning, sorry. However, I cannot tell you there's one type of surface modification that is the gold standard for to induce the best type of osseointegration. These are some basic concepts about mechanical considerations. So a greater surface roughness increases the potential of biomechanical interlocking. Of course, if we have a rough surface in a somehow porous material like bone, a rough surface is going to promote a better interlocking, a better fixation. Rougher implant surface also have a higher percentage of bone to implant contact, and also a higher torque removal than machine surface. So if all this irregularity makes the possible bone to implant contact higher, therefore this is another possible advantage that comes with the rough surface implants. So the little bit of bone biology very quickly. You probably already know that bone is a specialized connective tissue that is composed of organic and inorganic elements. So the organic matrix of bone makes approximately 30-35%. We have mostly type 1 collagen, 90-95%. The rest, 10%, is represented by non-collagenous proteins, proteoglycans, growth factors, And also, of course, there's the crystalline salts, the inorganic component, which represent the majority of the of bone itself, mostly is composed by hydroxyapatite. We are going to talk about the mineralization process of the how there's a deposition of crystals in order to form the hard structure of bone. But first we need to mention that these are the cells involved in the bone biology and bone homeostasis. So we have the precursors of the osteoblasts, the pre-osteoblast, and the osteoblasts are ultimately the cells that are responsible for bone formation, and they are the one that synthesize the matrix component and mediate the mineralization of the matrix. We do have endothelial cells, of course, because there's bone, especially in the vertebral canals. There's blood, sorry, in bone, and of course we do see endothelial cells. There's the osteocytes, which is these stellate shape cells that orchestrate the osteoblast and osteoclast function and are basically the brain of the bone. They are able to recognize all the possible stimuli to the bone itself. And then we do have the osteoclast, which are the one involved in the resorption of bone. So we have the osteoblasts involved in the deposition, the osteoclast, which are involved in the resorption. The progenitor cells are the monocyte and macrophages. And so they are involved in the matrix degradation. We need both because you know from previous studies that there's a continuous turnover of bone, right? So this is a basic concept to keep into account to understand how the osseointegration works and how an implant can fuse with the bone itself. We see here the osteoblast cells in line, in column. Those are the ones that promote and create and produce the osteoid matrix. The osteoid matrix is at this stage unmineralized and is also known as an osteoid. We do at this point have a mineral nucleation that occurs, and there's the ions are formed, ions of calcium and phosphate. They ultimately form the hydroxyapatite crystal and make the bone become mature bone and hard bone. And so this takes a few months. So you see then is basically a formation that happens into layers. Three basic concepts that we need to, these are simple, but they are they are basically the foundation of the osseointegration. So first of all, now that we explained a little bit of bone biology, we brushed up a little bit of bone biology. First, we know now that the osteoblasts are the one that created and formed the bone matrix, right? Second, the bone matrix happens only by apposition. And third, when it mineralizes, there's no inherent capacity to grow. So now we do understand how is this concept, like that we know how the bone formation progressed from the already formed bone to a new type of a new bone formation. We can describe the two types of osteogenesis, the distance osteogenesis and contact osteogenesis. So in the distance osteogenesis, this happens in a machined surface implants. So in the distance osteogenesis, we do have a implant for bone formation and goes from outward to inward, so from the outside towards the implant surface. Instead, in the contact osteogenesis, we have not only the bone formation that happens to outward to inward, but also we can see the bone formation right over the implant surface, because the capacity of the rough surface to attract and retain blood induces the bone formation right over the surface. That is the the concept that helps you understand why the rough surface implants are the surface that today we use in implant dentistry, because we can promote a faster and more effective type of osseointegration. Blood means life, means bone, and therefore we have a more rapid and also more effective type of osseointegration. You can see there's a classical ossification front that in the distance osteogenesis goes from outside towards the implant surface. Instead, for the contact osteogenesis, we at the same time we have already the bone formation over the implant surface. And I don't want to sound a little bit arrogant or a little bit cocky, but for me it was pretty easy to understand these concepts, because I know that a rough surface pasta can retain a greater amount of tomato sauce, so compared to a smooth surface pasta. So make sure that you do not think that this is a real concept, that the tomato sauce retention concept does not exist, but it's very a good concept to help you understand why roughness is such a key factor for the osseointegration. This pasta, by the way, orecchiette, means small ears that are typical for my region. So if you see orecchiette at the grocery store, please remember me and this presentation. So now we can talk about the histology. I'll do it a little bit quickly, but these slides are going to be available for you. So they are very detailed, and I want to bring up this study is an animal model in which they basically sacrifice sacrifice dogs, and they did histology, and in order to follow the process, the formation of osseointegration. So what happens 2 hours after the implant installation? For the implant, when inserting the implant, it's very important the mechanical anchorage, or better, the primary mechanical stability. We want the implant to be mechanically, so at the macro, this is a macro consideration at the macro level structure. So we need an implant to be stable inside the bone. We don't want the implant to rotate or to not be stable. Okay, so that is very important, because that helps and promotes and facilitates the osseointegration. Also, at the time of the implant, after 2 hours, we already can see erythrocytes, neutrophils, and monocytes, macrophages. We have the network of fibrin, and then the platelet cascade, the growth factor, they're starting to come. Leukocytes, they're engaged in the wound cleaning process. And this is what basically how histology looks 2 hours only, the implant placement. At 4 days, we already can see in a rough implant surface, we have an early granulation tissue as formed, and that is close to the device, close to the implant itself. Instead, the granulation tissue in a machine type of implants is close to the parent bone. So it's close to the bone that was already there. And this is clear from this slide. So the organization, histologic organization, it's a little bit more confused for a machine surface implant. At 1 week, we can see the woven bone formation already, and the contact osteogenesis is already observed on a rough surface. As you can see, we cannot see it on a machine implant. At 2 weeks, this becomes more clear. We do have the woven bone formation is more pronounced. Woven bone is basically the new native bone. And in many regions also we can see already a bridging of the surface of bridging means we have bone formation from the external bone and the bone formed on the implant surface. At 4 weeks, we have osteocoating. We even start to see the primary spongiosa, but look at the quality of osseointegration at the bone to implant contact in a rough surface implant compared to a machine one. 4 to 16 weeks, basically most of the wound chamber were now filled with mineralized bone. The mature bone is now formed. you can understand now that this is why we want to wait usually from 6 to 12 weeks, ideally in order to be safe. We want to wait 3 months prior to load our implant with a crown, and therefore, you know, start the function for the implant, because we need to wait for the osseointegration process. That's why. There are models in humans. Of course, you making histology in human, obtaining histologies from humans is way more challenging. I just want you to bring up that we do have histology on human model, but the one that I showed you before is way more detailed and explained the osseointegration process very well. If you want to review it yourself, you can take a look at the slides, but I just breezed through the histology because of time. Now, loading is an important concept, because everything that we mentioned so far ultimately has a practical application. And so let's expand a little bit on loading. Loading at the time of Branemark, they recommended from 3 to 6 months, but of course more observation, more study, more research showed how we can actually wait a little bit less. So if you want to you're restoring one single unit, you can wait up to 3 months in order to be very safe. Some people also wait a little bit less than 3 months. Some authors recommend a little bit less than 3 months. But you need to bear in mind that there are 3 different types of loading protocols. Immediate, so when the prosthesis, the crown, is connected to the implant fixture within the first 48 hours, or early loading, the prosthesis is connected to the implant fixture after the first 48 hours, but prior to 3 months, and delayed loading at 3 months or after 3 months. Now, do we load implant all the time, every time, once the osseointegration process is completed? No. You probably heard about the immediate loading, the teeth in a day. It's possible, but case selection is key. I like this study because they analyze they take into consideration single unit and also full arch restoration. In general, though, the conventional loading and the immediate loading can be both very successful, almost at the same level, with the same odd ratio, with the same with similar results, but the case selection is of paramount importance. And I'm going to explain you why. And I'm going to navigate you through a case of immediate loading. So usually we do immediate loading for a full arch restorations, because was that not for single unit. If we want to do an immediate loading for single unit, we want to release the occlusion. We don't want the mechanical forces to be exerted over the fixture if we restore one single implant. However, very frequently we can do an all on 4, all on 6, or like full arch type of restoration and place a temporary restoration at the time of the implant placement. So, for instance, what is the concept behind that? If we connect all the implants together, we avoid the possibility of a micro movement of each implant, and we do not disrupt the osseointegration process. So we need to connect all the implants together, though. Otherwise, it doesn't have an application. So this is a case of a patient with that showed like an atrophic ridge, and we decided to go for, we cannot decide beforehand to go for an immediate loading. However, if the bone is compact and the implants are placed with a good insertion torque, there's a hypothesis we can prepare the case for an immediate loading. So here, this was the full thickness flag that was raised, and also you can see I marked an area with a little drill in order to flatten the bone, because we need a decent amount of height for the restoration to to avoid the restoration, to any break of the restoration. So implant flat, surface is flat, we place 6 implants. And this is an important part. So the implant were placed with a good insertion torque. We're going to talk about insertion torque right now. And by connecting the implant with an acrylic restoration, we limit the micro movements and therefore ensuring the osseointegration process. So the mechanical anchorage and primary stability is key for an immediate loading. Otherwise, it's better to wait for the osseointegration to be completed. The ideal insertion torque for immediate loading, roughly more or equal than 35 Newton centimeter, is kind of empirical. I would recommend more or equal than 35 Newton centimeter. Every author has different opinion, but let's say overall there's an agreement of this value. Then all the implants are connected. There's a prosthesis conversion, and this is done at the same time of the procedure. This is the immediate temporary restoration. This is how the patient leaves the practice, and this is just temporary. Ultimately, the patient is going to have a fixed restoration, like the definitive restoration. Now, the question now might be, how is the bone matrix organized once we decide to opt for an immediate loading, if the case is a good case for immediate loading? They noticed histologically that the quality of the osseointegration does not change. There's a higher quantity of transverse collagen fibers and present a high level of mineralization. So these are the difference of unloaded versus loaded type of implant placement. The dynamic of the osseointegration and immediate loading also are effective, but as I said, the case selection is critical. So this is a study of on a human model at 4 weeks, and at 8 weeks they noticed that the bone to implant contact of the implant was high, and also the quality of the osseointegration was also very, very effective. So if we decide to go for immediate loading and we pick the right case, it looks like that the bone to implant contact and in general the quality of integration is effective as well. Now, a little bit of a small parenthesis about the bone to implant contact. We don't need a sky-high implant contact in order to have our implant successfully in place for a long period of time. However, that is also, if it's high, it's better, and it is can tell us how the quality of the osseointegration was. Insertion torque, last consideration to do about the insertion torque and the osseointegration. We need to mention that the insertion torque can be defined as the measurement of the resistance that the implant encounters during its advancement in the apical direction by means of a rotary movement of its axis. So basically, how strong the how high is the quality of the mechanical anchorage at the time of implant placement, and usually measured in Newton centimeters. Now, a question is osseointegration affected by the quality, the amount, the number of the value, sorry, of the insertion torque? Not really. Meaning that if I have an implant with a good insertion torque, meaning 35, 40, 45 Newton centimeters, I can think about possible loading options. That definitely it's better to have an implant with a high insertion torque. I can place an healing abutment, for instance, without being worried of the mechanical forces exerted over the head of the healing abutment. But if the insertion torque is low, and so maybe the implant is even spinning, but if the insertion torque is low and I leave the osseointegration process undisturbed, the quality of osseointegration is not is not lower than an osseointegration with higher insertion torque. And I think I am on time, and this is where you guys can reach out to me. That's my email. I opened this Instagram account, and it's new. I've been lazy, to be honest, but I'll promise that I'm gonna work on that and post some cases. I work and practice at the University of Missouri, Kansas City, and we talked about pasta before, and don't forget to pair it with a good glass of wine. Drink responsibly, and thanks again, and happy Mother's Day.
All right, thank you, Dr. Baliche, for that wonderful. This is like key. I think everybody should listen to these lectures first. If you want to place implants, you should understand something about the biology. You know, placing implants is not the first thing. I think this is, we have to go back and really, so this is recorded, so you can go back and really sit down and understand what is happening, because it's easy to just, you know, the process of placing implants seems easy. You just cut and you drill it in and you just put it there. You need to know exactly what is going on and how that affects, you know, there's so many things that we should learn. And I think this lecture is foundational. You know, I think, you know, even in my studies, back at the university, we had a lecture on osseointegration, and that was just key. You know, thankfully, we have a lot of people from different parts of the world today. So hopefully we can use this and change the minds of people about, just so that they understand. And hopefully, I'm hoping that dental students in universities in developing countries will have access to these videos. My goal is that at the end of this year, I should make it a core course. I know you are taught in your courses, but I mean, your lectures are with articles. So you're not using just like a textbook which gets outdated. You are using, evidence-based articles that are, and that are more recent. So this is really key. Thank you so much. I think you do have a question here. Okay, no, I think that explains. You said she was talking about what text would, what would you say about that? Like a reference material in understanding these concepts.
Well, I think that this lecture is a good summary overall.
Yes.
I think that I give some reference also from articles from histology. When we place, I want to just say that when we place implants, we really challenge biology. We try to replicate a very complex structure like a tooth, and with a prosthesis, with artificial materials. And so there are so many things that we need to take into account when we deal with implant placement. Understand that everybody can place an implant. Well, every dentist can place an implant, but there's a big difference in between placing an implant and understand what's going on and respect biology. And we ultimately want to deliver a long-term successful treatment plan. That's why understand that the osseointegration is at least the first step in implant dentistry. Text, I would say that, there's no, probably, here, especially in the United States, we are in an academic institution. We recommend, for instance, like the Carranza or like the Lang. There are different type of, they can email me and I can give them more specific, more detailed references. But I think that overall,
yes, your lecture provides, so I think we should go back and we have to dissect his lecture. He has so many articles there. So as part of our summary, we're going to look for, I would provide the articles if you find, if once you go back and get them, get the titles so that you can read the articles where they're from. That way, you know exactly, his lecture will guide you because he has brought out the salient points in those articles. And that is really powerful. I want to talk about the length of an implant in terms of short implants, and you're talking about loading. So what's the minimum length?
So implant dentistry has changed over the years. We talk about Brannemark, but then I don't know if you remember, there were, I talked to the audience in the past, there were the blade implants, we learn through observation. Implant dentistry is a relatively new type of field. And also through observation, we noticed lately that the length of the implants is becoming less important for the osseointegration and for the success of an implant. In the past, we used to go for the bicorticalism, these huge implants that try to encroach the cortex of the most coronal and apical cortex of the ridge. We don't do that anymore. Today, we have a lot of studies that show that 6 millimeters implants are effective in atrophic posterior maxilla, or also at the level of and also in the mandible. There's more studies about in the mandible because of course regenerate vertically the bone in the mandible is more challenging than do a sinus lift. But today with short implants are implants from 6 and 7 millimeters. 8 millimeters is standard length implants. And the more we move forward, the more 6 millimeters implants are going to be a valuable option, I believe, in the future. What's the drawback? In terms of osseointegration, not a big difference. Yes, of course, if we place an implant 6 millimeters in a very porous bone, a poor quality bone at that point, maybe you want to undermine the site, but the osseointegration is not very much affected. If we leave the process undisturbed. So I'm an advocate for decreasing the implant length myself. We also wrote that we collaborated to a book about short implants. So I'm one of those that likes those type of implants.
Okay.
You don't need to play super long. Another thing that I want to take into account, I want to just practically, there's the disadvantage is that we might see a little bit more resorption. The shorter is the implant, a little bit more challenging can be the resorption. Don't place ultra short implants for now. Maybe we mean 5 millimeters and shorter. Yeah, that's it. I forgot the other thing.
Okay. You have anything to say about implant fracture?
Implant fracture. What about implant fracture?
I know there's a question here about that the implants are made to withstand a lot of mechanical stress. So why do you have implant fracture? That's what the question said.
That's a very good answer. So we do have depends also what is the what type of connection you have, and fracture is difficult concept to standardize and to study in dentistry, in implant dentistry. There are so many variables involved. So we cannot say, okay, this type of implant fracture for sure. However, empirically, an implant with a narrow diameter in a posterior area, if we place an implant and we want to exert a lot of mechanical load of a big crown, a small narrow implant, very likely that implant might fracture. So but as I said, there's no like an absolute evidence, but I can tell you that some companies claim that their implant, their alloys are they're stronger than others. We don't have an absolute truth, but proof of concept, if you place a narrow implant at a big crown and you put it in a first maxillary molar, maybe you might have a fracture.
Okay, all right. Thank you so much. I know we have a part 2 of where you're talking about peri-implantitis. When you said sometime in July?
Yes, we can agree on a date. End of June, July.
Okay, all right. Okay, I would get back with you and communicate that to the rest of the group. Thank you so much. We have had a fantastic morning from some awesome and phenomenal Italians. All right. Happy Mother's Day to everyone out there, to your mom, to everyone who you call mom, and who is some people are waiting to be mothers, and happy Mother's Day to you. Thank you so much, Dr. Riccardo, and thanks to this tag team from Italy taking on implants and changing the world. Thank you so much.
Thank you, everybody.
How do you say thank you in Italy?
Grazie a tutti.
Grazie a tutti. Everybody, that's what I'm going to say to you. Grazie a tutti. I will be in Italy very soon because Ricardo is taking me for some a tour later in the future.
True. Grazie a te, Ugo. Grazie,
All
Dr.
right.
Balice. Bye-bye.
Okay.
Everybody.
All right. Thank you, sir.